يعطيك العافية. أنا الدكتور محمد سليمان. اليوم نحكي عن الأبر جي آي بليدنج بريفلي، الأبروش تبعهم والإيرلي مانجمنت خصوصا في الإمرجنسي ديبارتمنت. الليرنينج أوبجكتيفز لهذه المحاضرة راح تكون evaluate patients and identify the likely underlying reason for upper GI. يعني بهمنا نعرف شو الديفرنشال بالأبر جي آي bleeding. Describe the appropriate resuscitation in the emergency department mainly, mostly for moderate to severe upper GI bleeding. Demonstrate a rational approach to medical therapy in patients with upper GI bleeding. Apply appropriate risk assessment tools to identify high and low risk patients. راح نحكي عن multiple scores regarding risk stratification of patients with upper GI bleeding. Identify patients who would benefit from early referral to critical care area and consideration of urgent endoscopy. راح نحكي لأنه في مرضى بالأبر جي آي بليدنج ممكن نعمل لهم اوت بيشنت اندوسكوبي، في مرضى لا يحتاجوا انهم يدخلوا على المستشفى، وفي منهم بدهم ارجنت اندوسكوبي يعني مباشره زي المريض اللي بيطلع على الكات في الام اي مباشره بدك تطلعوا على الاندوسكوبي، في منهم بده اي سي يو ادمشن كريتيكال كير. فراح نحكي عن كل هذول البيشنتس. upper GI bleeding طبعا is very common presentation worldwide بالويسترن countries وحتى في الأردن. So definition of upper GI bleeding: any bleeding that's coming from a source proximal to the ligament of Treitz. ligament of Treitz هو غالبا بيكون بين الدودينم والجوجينم، يعني at the junction between duodenum and jejunum اللي هو الدودينو-جوجينال junction. بالنسبة للcauses الcommon causes of GI bleeding in UK and worldwide هي البيبتيك ألسر. البيبتيك ألسر disease هي the most common reason for upper GI bleeding. إذا بتلاحظوا الفاريشال bleeding 10%، بس هي عادة الموست سيفير والموست فيتال، بس الموست كومن هي البيبتيك ألسر ديزيز سواء كان جاستريك أو الوادنال ألسرز. طبعا في البالوري ويستير في نسبة من المرضى 15% no diagnosis، أحيانا بيكون erosions esophagitis malignancy vascular regions and other reasons. بس الموست كومن بيبتيك ألسر والموست lethal هو الأسوفيجيال varices. Pathophysiology of upper GI bleeding: most two common reasons. Peptic ulcer disease, the hemorrhage occurs from erosion to a blood vessels at the ulcer base. تعرفوا إنه الstomach has stomach lining usually protects the stomach from high acidity usually that helps digesting the food in the stomach. So any erosion in that protective lining will make the stomach more prone to bleeding from small blood vessels. The other differential, patients with liver disease usually due to increase in portal venous pressure, vessels in the stomach and esophagus become dilated and tortuous and will be more prone to bleeding. So regarding clinical assessment, we have like two presentations. Some of the presentation usually is a direct and easy to identify, like hematemesis and melena. And other difficult identifications, difficult to identify presentations, let's say syncope, dizziness, fresh PR, bleeding, hypotension, and tachycardia. So it depends mainly on the amount of bleeding. If you have like a mild continuous bleeding, mild continuous upper GI bleeding, patients usually present with melena, which is a black tarry stool, foul smelling usually. If the bleeding is moderate, let's say, the patient will present with hematemesis, like vomiting fresh red blood, or coffee ground vomiting. So it's coffee ground, and if it is more severe, will present with fresh blood hematemesis. And the last group of people, if the bleeding is so severe, they will present with syncope from dizziness from like sudden drop in their hemoglobin level, fresh PR bleeding, hypotension, and tachycardia. So if you have somebody with fresh PR bleeding, the bleeding is very severe, because usually what makes the stool black tarry, so the blood during like his passage from the GI tract, the digestive enzymes work on that blood, or hemolyze that blood and it turns the blood from red to black. So what you should look for in the history, any patients with suspected liver disease or known to have a liver disease, any patients with recent profuse vomiting might present with Mallory West tear. Usually this recent profuse vomiting, usually you can see it in alcoholic patients after drinking large amount of alcohol. Previous peptic ulcer disease or gastritis, any patients who's known to have H. pylori. Alcoholic patients, but it's not necessarily to have a variceal bleeding. Still, even in alcoholic patients, peptic ulcer disease more common than variceal bleeding. Medication, particularly non-steroidal and aspirin, increase the risk of upper GI bleeding. So if you can see that non-steroidal use, especially for long time, increase the upper GI bleeding risk fourfold. So what you should do in each patient when you suspect upper GI bleeding, you should do a digital rectal examination looking for melena. Regarding the approach to upper GI bleeding, it depends on the hemodynamic stability. If the patient is unstable, so call for help. Okay, apply high flow oxygen via non-breather mask. Okay, um, insert 2 large bore peripheral intravenous cannula. Take blood samples. We will talk about like in a few minutes. You need 2 large bore cannulas, usually 16 or larger. 18 can work also. You should start blood transfusion as soon as possible if the patient is hemodynamically unstable. You can give some fluid resuscitation. So regarding fluid in upper GI bleeding, we should only start IV fluid if the patient is hypotensive. So he's hemodynamically unstable and I don't have ready blood to give that patient. But if you have a blood, like in the emergency department, or negative blood ready to be given to the patient, you should start blood transfusion, not IV fluid. So IV fluid only if the patient is hemodynamically unstable, he's hypotensive, and there is no ready blood. But when you send blood samples to the lab, you should include a group unsafe and cross match. Urinary catheter, and you should measure urine output just to follow the response to your resuscitation measures, whether you are giving blood or fluid, and urgent referral to GI specialist and critical care. So blood transfusion has so many complications, side effects. We usually transfer patients if their hemoglobin level only is less than 7. But in patients with coronary artery disease or heart failure, we transfuse patients if the hemoglobin less than 9. Regarding platelet transfusion, we start transfusion if the patient is actively bleeding and his platelet is less than 50. Fresh frozen plasma, okay, fresh frozen plasma should be given, okay, in actively bleeding patients if the PT, INR, or activated partial thromboAPTT is greater than 1.5 times to the normal limit. So it's 1.5 times the upper normal limit. So if you have any prolongation more than 1.5 times the upper limit, cryoprecipitate can be used in patients with fibrinogen that remains less than 1.5 gram per liter despite giving fresh frozen plasma. Usually we give 2 units of fresh frozen plasma. If the patient is taking warfarin or any warfarin and he's actively bleeding, you should give him PCC, prothrombin complex concentrate, okay, according to the local protocol at your hospital. So regarding risk stratification, variceal bleeding. So variceal bleeding is uncommon, so it's less common than peptic ulcer disease, okay, even in patients with a known alcohol-related liver disease. Mortality is high, and the risk of rebleeding is 30%. So when to suspect variceal bleeding, if the patient is having any signs of decompensated liver disease, like he's jaundiced, he has ascites or encephalopathy. Known or suspected variceal bleeding should always be considered high because, as we said, the mortality risk is 50%. So variceal bleeding is more severe but it's less common than peptic ulcer disease bleeding. All patients should be referred for urgent endoscopy and admitted to critical care area if they have variceal bleeding. Prognosis is related to the severity of underlying liver disease than to the extent of bleeding. It depends on how severe the liver is affected with the underlying disease, not how severe the bleeding is. So here we will talk about risk stratification. So which patients should be admitted to the hospital and which patients can be discharged home with outpatient follow-up with the gastroenterology for an outpatient endoscopy. We use Glasgow-Blatchford score. We calculate this score in the emergency department, as I said, to determine the patients that needs admission and sometimes where you should admit the patients, whether in the floor or in the ICU. So the parameters of the score is the blood urea. So we have to send a kidney function test to determine the urea of the patient. So blood urea, each level will take a certain score, as you can see here. So each level, like from 6.5 to 7.9, will take 2 points, and so on. Hemoglobin level for men is different from for women. So any hemoglobin level less than 13 is abnormal for men, but in women less than 12, which is like 11.9. So this is less than 12, and 12.9 for men is less than 13. So each level will take also a certain points, like between 12 and 12.9, 1 point. Then systolic blood pressure. Each systolic blood pressure will take certain points. And then other markers like heart rate, pulse more than 100 will take 1 point. The presence of melena in NBR examination, this will take 1. A history of syncope associated with the presentation, 2 points. History of liver disease or hepatic disease will take 2 points, and heart failure will take 2 points. So we will calculate the all over score of the patients, and patients with a score of 0 can go home with outpatient follow-up. Any patients more than 0, like 1 and more, should be admitted to the hospital. And patients with higher score, they should be admitted to the ICU. So like 1 can be admitted for in the floor for endoscopy, maybe in the second day, like next day. But patients with higher score, like 5, 6, they should be admitted to the ICU. So only patients with a score of 0 can go home with outpatient follow-up in the GI clinic. There's another score which is ROCAL score. ROCAL score, we use it mainly to calculate the mortality rate, expected mortality rate. It depends on some preclinical signs and the endoscopy finding. So regarding the preclinical signs, which is age, shock, and presence or absence of comorbidities, maximum score in preclinical signs is 7. And post endoscopy findings, endoscopy, there's bleeding or there's no bleeding, and the diagnosis of endoscopy, maximum score is 11. So, and you can see here the mortality rate that's related to each score. So if the score is 0, it's 0.2, but if the score is 7, the mortality rate is 50%. So it does not predict the rebleeding risk. So ROCAL does not predict the rebleeding risk, but can be used just to expect or calculate the mortality rate with each patient coming with upper GI bleeding. So regarding risk stratifications, this is like a summary. The patients will have a low risk if his Glasgow-Blatchford score is 0. and we said that this patient is suitable to be discharged with outpatient follow-up and endoscopy. If the patient is having moderate risk, he should be admitted, okay, to the hospital for urgent endoscopy. Urgent means within 24 hours. But if the patient is having high risk with Roccal score pre-endoscopy 3 or more and he's hemodynamically unstable, okay, or he's known to have esophageal varices, we should start resuscitation and admit him to critical care area for emergency endoscopy. Emergency mean as soon as possible. So we have talked earlier about resuscitation, and we said you should call for senior, apply high flow oxygen, and insert 2 large IV cannulas. So what blood test do I need in patients with coming with upper GI bleeding? Venous blood gas, which can tell you the hemoglobin level. Okay, urea and electrolytes. We said that we need usually urea to calculate Glasgow plus Ford score. Full blood count, okay, coagulation, which is PT, BTT, and INR, liver function test to identify if the patient's having any underlying liver disease or he's having liver cirrhosis. A group and save and a cross match. You need chest X-ray and 12 lead ECG. We said because some of the patients with upper GI bleeding, especially if they have a pre-existing ischemic heart disease, will have signs of ischemia on ECG if they are bleeding and their hemoglobin level is too low. There's no rule. There's no rule to abdominal X-ray. I never done this investigation before. Chest X-ray, 12 leads ECG, yes. No rule for abdominal X-ray. So there is regarding medical therapy of non-variceal bleeding, especially peptic ulcer disease, there's some conflict about the using of PPI, which is proton pump inhibitors such as omeprazole or pantoprazole. So theoretically, PPIs can reduce bleeding by increasing the pH of the stomach, okay, leading to clot stability. And post endoscopy, they reduce the risk of rebleeding and the need for surgery. But there's no effect overall on the mortality rate. So the conflict was regarding using of proton pump inhibitor before endoscopy, because some of the studies found that using PPI before endoscopy, okay, will reduce findings of recent serious bleeding and the need for treatment during endoscopy. يعني لما نستخدم البي بي اي قبل الاندوسكوبي and the patient goes to the endoscopy, the gastroenterologist will not find the source of bleeding because PPI masks the source of bleeding because it results in clot stability. Okay, but they agreed that the use of PPI after the endoscopy is recommended. Okay, so using of PPI after endoscopy is recommended. There is no rule of using PPI before endoscopy in the emergency department. And there is no evidence that using PPI improves clinical significant outcomes such as mortality, rebleeding, or the need for surgery. So the learning part here, while using PPI are commonly used in the management of upper GI bleeding, there is little evidence of supporting their use in the emergency department. So all what we are talking about here is the use of PPI in the emergency department. No rule for PPI in emergency department. They usually start the PPI after endoscopy. So regarding octreotide, which is a somatostatin, it's not recommended for routine use in patients with acute non-variceal bleeding, such as peptic ulcer. So most of the bleeding is non-variceal. Said that variceal bleeding accounts for almost 10% of the upper GI bleeding. So there is no rule for somatostatin. Regarding antinofibrinolytic therapy, the most commonly widely used is tranexamic acid. There is no rule for using tranexamic acid in GI bleeding, although we use it in vaginal bleeding, in bleeding during trauma, but there is no rule for using tranexamic acid in GI bleeding. Regarding medical therapy of variceal bleeding, okay, there's 2 classes that are widely used in the management of variceal bleeding, which are ectreotide and vasopressin or terlipressin. So somatostatin, which is ectreotide, we use it to relax the vascular smooth muscles and reduce portal venous pressure, which is the main reason or the underlying pathophysiology of the variceal bleeding, which is the portal venous pressure. Okay, vasopressin causes arterial vasoconstriction, reduces portal venous pressure, but that put the patient at risk of end organ ischemia. There is no rule for the use of vitamin K in patients presenting to the emergency department with variceal bleeding, although it's necessary for the production of coagulation factors in the liver, but there's no evidence that there is any benefit of giving the patients vitamin K. So 20% of cirrhotic patients with acute variceal bleeding will develop bacterial infection within 48 hours. So there's a strong evidence of giving those patients antibiotic in the emergency department and during admission. The most two commonly used antibiotic is ciprofloxacin and ceftriaxone. You should give one of them, cipro or ceftriaxone. So regarding non-medical therapy, which is endoscopy, one of them, endoscopy is the gold standard for both confirming the diagnosis of upper GI bleeding and treating upper GI hemorrhage. The timing of endoscopy, it depends on severity and stability of the patient. If the patient is unstable, you should resuscitate him first and then send him to the endoscopy. If the bleeding is less severe and the patient is stable, endoscopy can be done within 24 hours. Common therapies during endoscopy include injection or thermal therapy for peptic ulcer disease, bleeding, and banding of esophageal varices in variceal bleeding. Endoscopy usually controls bleeding in around 90% of the patients. Mallory West usually stops without endoscopic intervention. So the timing of endoscopy depends on the severity of the infection. And we said we can determine the severity using pre-endoscopy assessment scores like Rockall score and Glasgow-Platchford score. Regarding balloon tamponade, okay, there's two common types of balloon tamponade. We use this balloon tamponade to stop bleeding. Okay, if the bleeding was so severe, because sometimes if the bleeding is so severe and you go for endoscopy and the patient is unstable, you'll not even be able to see the source of bleeding because the blood will be everywhere. So there is a Sanger-Stacking Blackmore tube, which is 3 lumen, or Minnesota tube, which is 4 lumen. This one. So usually the lumens, you will have a lumen to inflate this balloon, which goes in the stomach, and lumen to inflate this balloon, which remains in the esophagus, and another lumen to suction from the stomach, and another lumen to suction from the esophagus, to suction the blood. So a tamponade provides good control of bleeding in 90%, although most will rebleed within 24 hours. The main rule of this tube is to buy time to endoscopy. So suppose that you are working in a hospital and you don't have any endoscopic facility and you want to transfer the patients to another hospital. Okay, so you will apply this one if he has severe bleeding. So the purpose of the main use of these tubes just in severe bleeding. So in severe bleeding, and to buy sometimes to endoscopy. We said that these balloons usually we use it in case medical therapy failed and I don't have endoscopy facility, or it's not readily available. So it's not available right now and it needs time to be available. So, and the patient is still bleeding despite taking medical therapy. Usually, as we said, severe bleeding happens in variceal bleeding. So mainly the use of these balloon tamponades in variceal bleeding. So what are the steps of inserting this balloon? Patients should be intubated with rapid sequence intubation to secure the airway. You should test the balloon that everything is functioning. Okay, all the lumens and the balloons are working. We usually lubricate the tube and insert it at the depth between 50 and 60. Okay, as we insert the NG tube, but usually we insert it through the mouth will be much easier to insert it through the mouth, not through the nose. After that, after inserting the tube 50 to 60 centimeter, you inflate the gastric balloon with 50 ml of air. How to confirm that the tube and this balloon in the stomach? You send the patient for X-ray to see that there is gastric balloon in the stomach. Okay. And after that, after confirming that the gastric balloon in the stomach, you start inflating the balloon more and more, every time with 50 to 100 ml of air, up to maximum volume of 250 to 300 ml for Sange-Staking Blackmore tube, or 450 to 500 for Minnesota balloon tamponade. If you find a strong resistance, you should stop the inflation and clamp the port. And you need another X-ray to confirm the position after that. After inflating this balloon, which is in the stomach, okay, with 250, 300 if it is Sange-Staking Blackmore, or 400 to 500 ml if it is Minnesota, should apply some traction. Okay, so pull the balloon back against the gastric fundus, mark the tip, okay, traction with 500 ml of fluid. So you should connect the catheter from this side with a weight of 500 ml or even 1000 ml, which is 1 kilo, okay, to apply some traction for over this balloon, and this will help stopping the bleeding. It's like as applying pressure on the side of bleeding. The esophageal balloon should not always be inflated, but should only be inflated if bleeding continue despite inflating the gastric balloon. You should only inflate this balloon with 40 millimeter mercury. You should like use some kind of pressure measuring device to make sure that you only inflate it with 40 millimeter mercury. Every procedure we do in medicine has complications. What are the complications of balloon tamponade? So, esophageal necrosis or perforation sometimes, aspiration of the airway is not secured, mucosal ulceration from pressure, sometimes proximal migration of the tube causing airway obstruction, sometimes ongoing hemorrhage because the tube is not inserted in the correct way. So, what other options we have if endoscopy fails? Okay, we have surgery, angiography, and embolization, which is one of the interventional radiology, or a transjugular intrahepatic portosystemic shunt. This one also one of the radiological intervention that in which we connect the portal and hepatic venous system to reduce the portal venous pressure. So what are the pitfalls in treating upper GI bleeding? The most common is, and the most important, let's say the most important one, is failing to recognize patients with upper GI bleeding who requires a prompt resuscitation and urgent endoscopy. So any patients with hemodynamic abnormalities or patients with Rocal score of 3 or more. Those patients need critical care admissions and urgent endoscopy. If you have any patients with signs of shock and you find no reason for that, so he's not febrile, his inflammatory markers are normal, think about upper GI bleeding. Do rectal examination to avoid missing melena. Any patient with unexplained postural hypotension or syncope, there's a risk of upper GI bleeding. In terms of varicose bleeding, always remember that failing to secure the airway before inserting Sange-Staking tube can lead to aspiration. So you can't insert the Sange-Staking tube or any other tamponade tubes before securing the airway. And remember that if you have any patients with drop in his hemoglobin, any like old patients coming with drop in his hemoglobin, his blood pressure is low, think about GI bleeding also. Let's talk about some questions and scenarios. Let's say this, you have a 56-year-old man coming to the emergency department. He gives you a history of 4 large fresh red vomits and a black tar-like stool for 12 hours. Black tar-like, tar is like, which is the tar, which is very, very black. dark black, and usually with a foul smelling. On examination, he is clammy and has a cold peripheries. His pulses is 130 and blood pressure 70/40. And he has history of ischemic heart disease. So this patient has signs of shock. So what are the initial actions and the priorities from the following? So what do you think as we said, this patient in shock and he has severe upper GI bleeding. So we said that he needs high flow oxygen, he needs urinary catheter, yes. He needs some IV fluid, Hartmann, if we don't have blood ready to be given, okay, and he needs endoscopy. So we said that inserting Minnesota tube is only indicated if medical therapy fails, and there is no endoscopy facility. There is no rule for giving vitamin K. There is no rule for PPI. There is no rule for endoscopy. Terlipressin is only giving if there is evidence of hepatic encephalopathy and signs of liver cirrhosis like jaundice. And ectreotide, we use it only in patients with variceal bleeding. So this is the correct answer. Endoscopy, fluid, urinary catheter, high flow oxygen. And there is no rule for other interventions. So this is another question about the same case scenario. When should this patient receive red blood cells? If there is no response to crystalloid resuscitation, this is correct. There is evidence of further bleeding, this is correct. If the hemoglobin level is less than 7, and we said if less than 9 even if less than 9 in patients with ischemic heart disease or heart failure. This is the correct answer. Just focus on this point. Point C, if hemoglobin level is less than 7 or if less than 9 in patients with ischemic heart disease or heart failure. Another question, which of the following are indication for surgery in upper GI bleeding? Increasing transfusion requirement post endoscopy. This is correct. Initial ROCAL score on presentation more than 5. No, you should start medical therapy and endoscopy. There is no rule for immediate surgery. Failure to respond to initial fluid resuscitation. This is no also. Evidence of variceal hemorrhage on endoscopy. No, you can start medical therapy and endoscopy and do a rubber band ligation for the esophageal varices. Failure to control bleeding at endoscopy. This is yes. This is one of the indication. Significant rebleed post endoscopy. And this is another indication. So the correct answer A, E, and F. So this is the correct answer A, E, and F. By the way, surgery is rarely indicated in the management of of upper GI bleeding. Most of them will stop spontaneously, and endoscopy only will be of a diagnostic value, okay, to guide further treatment in the future. Some of the patient fails medical therapy, and they will require endoscopy, diagnostically and therapeutically. So this is another case scenario, which is a 45-year-old man with non-alcoholic liver disease. We said earlier that even if the patient is known to have alcoholic liver disease, that does not mean that variceal bleeding is more common than a peptic ulcer disease. So still peptic ulcer disease is the most common reason for bleeding even in alcoholic liver disease. So this patient is coming to the emergency department following a large episode of hematemesis. He looks unwell, clammy, pulse of 120 and blood pressure of 80/40. Which of the following factors are highly suggestive of variceal bleeding? Evidence of hemodynamic instability, this is no. Previous variceal bleeding, yes. Heavy alcohol intake, no. Known liver disease, no. Severe upper GI bleeding, no. Jaundice, yes. Encephalopathy or encephalopathy, yes. Ascites, yes. So the 4 signs that make you suspect that this patient is having variceal bleeding is ascites, because this is one of the signs of liver cirrhosis, encephalopathy, jaundice, and history of previous variceal bleeding. And this is the answer here. So regarding the patients in the previous scenario, suppose that he's having variceal bleeding, what he should be given. So he had the signs of shock, and there is no blood ready. I will give him Hartmann solution 500 stat. High flow oxygen also should be given. Urinary catheter should be inserted, okay, to follow the response of treatment, resuscitation treatment. Terlipressin 2 milligram IV bolus, yes. And antibiotic, we said that antibiotic is indicated in patients coming with variceal bleeding. This is the same question. This is the answer of that question. Okay, we said fluid, oxygen, catheter, terlipressin, and antibiotic. This is another question. So he continues to bleed despite resuscitation and medical therapy, and you decide to insert Minnesota tube. We said that these tamponade tubes is indicated if the patient fails to respond to medical therapy and you don't have endoscopy facility. We said that in Minnesota tube, how many ml of air total should be inserted? We said it's 450 to 500, which is C. And this is the answer for this question. It's C. So some key points. This is some key points about the upper GI bleeding. So mortality is still high. Okay, it's around 10%. Mortality of variceal bleeding is very high. It's 50%. We said that Glasgow Blatchford score can identify low-risk patients who may be suitable for AD discharge and outpatient management, or patients who needs admission to the hospital and urgent endoscopy. Pre-endoscopy Roccal score can identify high-risk patients who might benefit from critical care and urgent endoscopy even. There is little evidence to support intravenous use of PPI like omeprazole in the emergency department. Intravenous terlipressin and broad-spectrum antibiotics are both indicated to patients suspected variceal bleeding. You should at least be familiar with the use of Sange-Staking Blackmore or Minnesota tubes, as you might need to insert one of them in the emergency department, especially if the patients have severe bleeding, fails medical therapy, and you don't have endoscopy facility.